Hi everyone. Hi. Hi Ugandhar. Right. So let's begin with our session today. So before I begin my session, I want you to know that Unacademy is coming up with this ultimate revision target 150 plus in FMGE December 2023 examinations. Good morning Medico. Good morning Ugandhar. So please note that this particular batch has 150 plus hours of high yield revision practice which is covered in live sessions. There are rapid revision, tests and discussion as well as live dot solving, and there are important topics and last minute tips and tricks are provided. So this particular subscription is available only at 6,650 rupees, okay, from its previous value of 10,000 rupees. So please do subscribe to this, and when you do subscribe, please use the code mentor, okay, MENTOR is the code that you need to use for this particular subsidized subscription, right? Apart from that, remember that currently you have 20% off on all the Unacademy subscriptions. So as I told you, this target 150 for FMGE December 23, duration of this batch is 4 months, and currently the offer price is 5,600. This particular price is valid only till August 25. Okay, so you have just 3 days more. Please do subscribe to this and please use the code mentor when you have to access the discount. Okay, so please use the code mentor. Also, I would like you to know about the iconic subscription of Unacademy. Now, the iconic subscription is where you get everything. You have access to the Unacademy Plus subscription. The Unacademy Plus subscription gives you a concise syllabus coverage through live batches. You have recorded content. You learn from India's top educators. You have integrated sessions as well as question bank with 75% case-based questions. You also get access to PYQs, live tests and quizzes. Along with this entire Unacademy Plus subscription, you also get notes. Now these notes, they are based on the recorded content. So you separately do not need to make notes. There is a separate section for high yield MCQs and PYQs, and there are increased visual aids like images, flowcharts and tables. In addition to all this, you also get a mentoring session where you are coached and mentored by the Unacademy educators as regards to the preparation strategies, the educator experiences and the peer success stories. So you please use this particular discounted rate that is available currently. For 6 months it is only 21,840 after a 20% discount, and for 36 months it is 40,320, a great investment for all your future competitive examinations. Please do subscribe to this iconic subscription, and when you use, please do use the code mentor. MENTOR is the code that you need to use to access to this particular iconic subscription at a subsidized rate. Okay, so with that, let's begin with our session for today. Let's go to the first question. I want you to be very interactive. Okay, so these are all FMGE questions. They are all easy questions. Okay, nothing that is very difficult to answer. So the first question is, Donovanosis is caused by Haemophilus ducrei, Leishmania donovani, Klebsiella granulomatis or Treponema pallidum. Can someone write the answer? Ugandhar, Medico, anyone? Donovanosis is caused by. Anyone would want to answer? Okay, so please remember that Donovanosis is not caused by Leishmania donovani. Okay, so at least remember that much, that Donovanosis is not caused by Leishmania donovani. Leishmania donovani causes leishmaniasis. Haemophilus ducreyi causes chancroid. Okay. Klebsiella granulomatis causes donovanosis, and the other name for donovanosis is granuloma inguinale. Okay, and Treponema pallidum causes syphilis. Right? Please confirm if I am audible, visible, both, because I am not getting answers to the questions. Am I visible? Am I audible? All okay? Please give me a thumbs up if you can see me as well as hear me. Is the streaming fine? Yes, thank you, Siddharth, for the confirmation. So primarily, please remember that donovanosis is a sexually transmitted genital ulcerative disease, and it is caused by Klebsiella granulomatis. It infects the skin around the genitals, groin or the anal area and causes ulceration and destruction of the skin. Okay, so now you have to remember certain basic, at least the 5 ulcerative STDs thoroughly, because there are a lot of MCQs that have come in the past and they are expected even now. The donovanosis is also called as granuloma inguinale. It's a chronic granulomatous, locally destructive ulceration which is caused by Calymatobacterium granulomatous or Klebsiella granulomatous. It is one and the same thing. Okay, now what you have to remember about the characteristics of the ulcer. These characteristics, they are extremely important. Okay, so please remember that in donovanosis you have a painless ulcer. Okay, so you have a painless ulcer. They are foul smelling ulcers and there is exuberant granulation tissue that occurs on the floor. It has a beefy red appearance and it bleeds easily on touch. So these are the characteristics that you need to remember. Painless foul smelling ulcer with exuberant vascular granulation tissue on the floor giving rise to a beefy red appearance which bleeds easily on touch. Now please remember, in donovanosis you do not have lymphadenopathy. Okay, so there is no regional lymphadenopathy in donovanosis, but there are granulomatous swellings that occur at the site of the lymph node. Okay, so that means there will be granulomatous swellings occurring in the inguinal area, and hence since it is not a true lymphadenopathy but a granulomatous swelling, these are called as pseudobubos. So this is a very important MCQ. Please remember, donovanosis, you see dono pseudo. Okay, so you see pseudobubos in donovanosis, and because it is a chronic long-standing granulomatous ulceration, you can have squamous cell carcinoma occurring as a late complication of donovanosis. Now, how do you investigate donovanosis? So, if you have a patient coming to you with red exuberant granulation tissue on the floor having a painless ulcer, what you can do is you can take a biopsy of that particular granulation tissue. You can take that biopsied material onto a slide and you crush the biopsied material between the two glass slides. So that will give rise to a crush smear, and you stain it with right stain or Giemsa stain, and that will show the presence of parasitized histiocytes which contain the Donovan bodies. Okay, so this is a parasitized histiocyte which is containing the Donovan bodies. These Donovan bodies, as you can see, they have a closed safe tip in appearance. Okay, so remember, closed safe tip in appearance within the histiocytes is seen in donovanosis, and these bodies are called as Donovan bodies. Okay, please remember this. It's again a very important MCQ. So what you need to remember about the characteristics of the ulcer in granuloma inguinale or donovanosis, it's that it is a painless ulceration which is chronic, granulomatous, and it has exuberant granulation tissue on the floor which bleeds on touch. There is no actual lymphadenopathy, but there are granulomatous swellings occurring at the site of the inguinal region, and hence they are called as pseudobubos. You investigate it by doing a crush smear and staining it with Wright's or Giemsa stain, and that will show you the presence of Donovan bodies. How do you treat donovanosis? For treatment, you can give azithromycin 1 gram single dose per week or 500 milligram daily for at least 3 weeks until all the lesions have completely healed. Alternative regimes are capsule doxycycline or tablet ciprofloxacin, erythromycin or TMP SMX. Okay, they can also be used, right? So this is all that you need to know about Donovanosis. Now, let's go on to the next question. You have the question as fungal infection which is acquired by traumatic inoculation is it Sporotrix, blastomycosis, coccidioides or paracoccidioides? Brinda says it's A. Anyone else would also want to answer? Yes, Nisar says it's sporotrichosis. Yes, so we have two people. Yes, so Brinda and Nisar, both of you are right. The correct answer is Sporotrix. Okay, so it is Sporotrix. Sporotrix schenki is the organism which is a thermally dimorphic fungus that lives on vegetation. It is associated with a variety of plants, grasses, trees, moss, bushes and other horticultural plants. So that is why sporotrichosis is also called as rose handler's disease, right? So that is why it's also called as rose handler's disease. And remember the occupations in which you see sporotrichosis. You see sporotrichosis in florists, you see it in farmers, and you also see it in gardeners, right? So basically remember why do you see it in this occupation is because it is associated with plants, trees, grass, moss, rose bushes and other horticultural plants. So what happens is when there is a thorn prick, usually the conidial or the hyphal elements of Sporotrix schenki, they are introduced into the skin by trauma. And once there is a traumatic inoculation into the skin, it causes a chronic granulomatous infection which usually traverses along the lymphatics. Okay, and it causes nodulo-ulcerative lesions that occur in a linear fashion. Okay, so that is why remember for sporotrichosis you have linear involvement because it has specific involvement of the lymphatics. Okay. Now, it can also affect the lungs and this manifestation mimics chronic cavitary tuberculosis and tends to occur in patients with impaired cell-mediated immunity. These are satellite lesions. Specifically, if you have to consider satellite lesions, you would say are present in borderline tuberculoid Hansen's disease. We do not describe it for sporotrichosis. Okay, so there are distant lesions where distant to the site of inoculation in a linear fashion, but they wouldn't be called as satellite lesions. Okay, so satellite lesions are seen in borderline tuberculoid Hansen's disease. Satellite pustules, these are seen in chronic candidiasis. Okay, now so remember the most common presentation of sporotrichosis is the lymphatic type. Now in the lymphatic type you have a linear chain of ulcerating nodules and sinuses along the lymphatics. On histopathology you see small cigar shaped or oval yeasts which are surrounded by a radiating eosinophilic substance. They are also called as asteroid bodies. So see, this is an asteroid body. Please remember, asteroid bodies are small cigar shaped or oval yeasts which are surrounded by the radiating eosinophilic substance. So that is called as asteroid bodies. Fish tank granuloma is caused by Mycobacterium marinum and it resembles sporotrichosis. So please remember, in the question if they tell you that the patient's occupation is a fish handler or a swimmer and is having lesions that resemble sporotrichosis, the answer will be fish tank granuloma which is caused by Mycobacterium marinum. Okay, so here you can see there are multiple nodulo-ulcerative lesions which are occurring in a linear fashion. Okay, so this happens because of the lymphatic spread. Now, next question for all of you. Which of the following is not involved in urethritis? The question is, what is not involved in urethritis? Is it trichomonas, H. ducrei, chlamydia, or gonococcus? Not involved. Can anyone tell me the answer? Anyone would want to answer this question? Nisar says B, Shobhi says C. Okay. Anyone else to break that? Anyone? Okay. So Nisar, you are right. The correct answer here is H. ducrei. H. ducrei is responsible for causing chancroid, which is an ulcerative STD, right? It's an ulcerative condition and it is not involved in the causation of urethritis. Chlamydia causes non-gonococcal urethritis. Gonococcus obviously causes gonococcal urethritis, and trichomonas is also one of the causes of non-gonococcal urethritis. Okay, so the correct answer here is B. So we can say the bacteria that commonly cause urethritis would include E. coli and other bacteria which are present in the stool. Then gonococcus, which is sexually transmitted and it causes gonorrhea. Chlamydia trachomatis, which is again sexually transmitted and causes non-gonococcal urethritis. HSV 1 and 2 can also cause urethritis, and trichomonas is another cause of urethritis. Okay, so remember these things: E. coli, other bacteria present in the stool; gonococcal causes gonorrhea; chlamydia causes NGO; HSV can also cause trichomonas both can cause urethritis. Now let's go to gonococcal urethritis. It is caused by Neisseria gonorrhoeae. Now please remember it has a very short incubation period. It's just 2 to 8 days. So usually the history is that the patient has had a sexual exposure within 2 to 4 days of the exposure. The patient starts developing intense burning sensation while passing urine, and one also starts developing thick purulent urethral discharge. Okay, so remember in cases of gonorrhea, the males are much more significantly clinically symptomatic as compared to females. There is thick purulent urethral discharge, and others can have prostatitis, epidermoorchitis, though testis is not involved. In females, the primary infection does not occur in the vagina, but it occurs in the endocervix. Okay, and this can go often asymptomatic, but it can cause cervical discharge, salpingitis, and pelvic inflammatory disease as a complication. Now, how do you diagnose gonococcal urethritis? You have that thick purulent urethral discharge. Take that discharge, subject it to a gram stain, and then you will be able to see the presence of gram-negative diplococci. Okay, so gram-negative diplococci, they are seen outside as well as inside the neutrophils. The culture is the gold standard. You can also do a nucleic acid amplification test on urine, urethral discharge, cervix, or the vagina. Now, the treatment of uncomplicated anterior urethritis caused by gonococci is injection ceftriaxone, 250 milligram intramuscularly stat dose, or you can give tablet cefixime 400 milligram single dose along with azithromycin 1 gram stat. Now remember that this azithromycin 1 gram stat is to treat the chlamydia. The reason being that gonococcal infection is usually accompanied by chlamydial infection. If you just treat the gonococcal infection, the chlamydial infection will persist. Okay, and that will give rise to something called as post-gonococcal urethritis, where the chlamydial infection continues to cause discharge per urethra as well as symptoms. Okay, so remember that always when you are treating gonorrhea, also treat chlamydia simultaneously. So the treatment would be tablet cefixime or injection ceftriaxone. Along with it, give tablet azithromycin 1 gram stat. So this is the thick kind of discharge, thick mucopurulent discharge that you see in gonorrhea. Now, non-gonococcal urethritis is caused by chlamydia, and there are other organisms which cause it, like ureaplasma, mycoplasma genitalium, and rarely trichomonas. It is the most common bacterial STI in the world. The incubation period is 1 to 3 weeks, so it is a little longer as compared to gonorrhea. Now, the differences between the discharge of gonococcal urethritis versus non-gonococcal urethritis is that in gonococcal urethritis, the discharge is thick and mucopurulent, while in non-gonococcal urethritis, the discharge is watery thin, mucopurulent, and it can also complicate into epididymitis and pelvic inflammatory disease. The diagnosis is via a nucleic acid amplification test which is done on the urethral swab, and it is the only recommended test. So please remember, nucleic acid amplification test is done on the urethral swab and it is the only recommended test. The treatment for non-gonococcal urethritis is azithromycin. Now, let's go to the next question. Organism causing lymphogranuloma venereum is Chlamydia trachomatis, Neisseria gonorrhoeae, Treponema pallidum, or Haemophilus ducrei. So Nisar says it's Chlamydia trachomatis. Anyone? Anand also says it's a yes. Chlamydia trachomatis is the correct answer. Chlamydia trachomatis serovars L1, L2, L3. These are the serovars which are responsible for causing lymphogranuloma venereum. Neisseria gonorrhoeae causes gonorrhea. Treponema pallidum causes syphilis. Haemophilus ducrei causes chancroid. Okay, so LGV causing organisms are trachomatis, Chlamydia trachomatis L1, L2, L3. Okay, so remember the other conditions that are caused by Chlamydia trachomatis. When it involves the eye, it causes conjunctivitis and trachoma. When it involves the respiratory system, it can cause pneumonia. When it involves the genital tract, it can either cause urethritis or it can cause lymphogranuloma venereum. And diagnosis of LGV or other infections which are caused by chlamydia include the NAT, that is nucleic acid amplification test. Okay, now remember that there are 3 stages in lymphogranuloma venereum. The first is the so Nisar says HP bodies, Halbert Stader Provazake inclusion bodies. In Nisar, they are not seen in LGV. They are seen in molluscum contagiosum. Henderson-Peterson bodies are seen in molluscum contagiosum. Okay. Now, please remember that in lymphogranuloma venereum, there are 3 stages. There is a primary genital stage where you see a transient superficial painless erosion. So this is very important. There is a painless erosion and this sometimes goes unnoticed by the patient. Then comes the secondary inguinal stage where you see painful unilateral or bilateral inguinal lymph nodes which are called as buboes. And in the tertiary stage, there is fibrosis of the lymph nodes causing obstruction of the lymph drainage, and there is lymphedema and genital elephantiasis. The elephantiasis is the enlargement of the genitalia which is distal to the obstruction. Okay. Now, lymphangiectasia can happen and there can be rupture of these lymphangiectasias to cause lymphoria, which is oozing of lymph. In females, when there is elephantiasis plus chronic genital ulceration of the overlying skin, this process is called as estheomene. So again, this is an important MCQ. Estheomene is seen in lymphogranuloma venereum. The diagnosis is nucleic acid amplification test, which is the test of choice. Complement fixation test is most commonly done. And freeze intradermal test was an ancient test that was done and it is not done now. The treatment is doxycycline 100 mg 2 times in a day for 21 days. And if there is a bubo which is very painful, one can also needle aspiration and drainage can be done. Now, as Nisar had rightly mentioned, that you see buboes, okay, you see buboes above and below the inguinal ligament, and the site of the inguinal ligament is seen as a groove, okay. So this is called as groove sign, which is seen in lymphogranuloma venereum. Pararectal lymph nodes are also enlarged, and rectal inflammation can cause strictures and fissures. Okay, now we have the last 4 minutes in this particular session. I want everyone to be participative. Let's go to the next question. A child is born covered with a thick membranous coat. What is the possible diagnosis? Is it lamellar ichthyosis, X-linked ichthyosis, Icthyosis vulgaris, or Icthyosis acquisita? Can anyone answer? Okay, so the correct answer here is lamellar ichthyosis. Now, basically, they are talking about a thick membranous coat which is present at birth. So, this thick membranous coat is nothing but the colloidal membrane. Okay, so if you see the colloidal membrane, it can further eventuate into lamellar ichthyosis. Icthyosis vulgaris does not present at birth as a colloidal membrane. Icthyosis vulgaris is usually seen around 3 to 4 months after birth. Okay, so correct answer is not Icthyosis vulgaris. Icthyosis acquisita is an acquired condition, so obviously it cannot be present at birth as a colloidal membrane. X-linked ichthyosis also does not present at birth. It occurs a little earlier, but it does not present at birth. It occurs within 2 months of age, but it does not occur at birth. Lamellar ichthyosis is the correct answer here. Okay, so ichthyosis is one of the most common genodermatosis. It is characterized by dry, scaly, xerotic skin over the body. The scales are dull brown and black. So primarily the basic defect is the impairment of the barrier function and inability to maintain the moisture. Colloidal baby is the term that is used to denote a newborn baby with ichthyosis. The newborn baby is encased in a shiny membranous coat which is called as the colloidal. And this is seen in lamellar ichthyosis. So as I mentioned, ichthyosis vulgaris does not present at birth. It presents at around 3 to 4 months after birth. It's an autosomal dominant condition characterized by fish-like scales. There can be associated atopy and keratosis pilaris. The flexures are spared, the extensors are involved, and palms and soles can be involved with increase in the skin markings. X-linked ichthyosis occurs before 3 months, and it occurs because of the deficiency of the enzyme steroid sulfatase. It's an X-linked recessive condition. There are fine, large, dirty brown looking scales, and the palms and soles are spared, extensors are spared, and the flexures are involved. Associated features include undescended testes and corneal opacities. Lamellar ichthyosis is present at birth, presents as a colloidal membrane. So here you can see that there is a thick parchment-like membrane which is encasing the entire body. It is also giving rise to ectropion. It is also giving rise to eclabium, and there is a deflection deformity of the fingers as well. So this is an autosomal recessive condition. When this colloidal baby further, the membrane ruptures and disintegrates, it can further evolve into lamellar ichthyosis. Lamellar ichthyosis is characterized by plate-like scales. So as you can see, there are large plate-like scales looking like an armor. Palms and soles are involved. Extensors and flexures both are involved. Then going on to bullous ichthyosiform erythroderma. In this condition, there is no colloidal membrane at birth. It presents as a bulla. It's an autosomal dominant condition where there are blisters at birth, and then these soon leave behind rough scales. Palms and soles are involved, extensor flexors are also involved, and it can eventuate into erythroderma. So that finishes our topic on ichthyosis, and that finishes our time for today. Please do subscribe to Unacademy, and when you do subscribe, please use the code MENTOR. MENTOR is the code that you need to use. And do study well for your upcoming FMGE examinations. Do well, and thank you very much for a patient listening as well as being interactive. Bye and have a nice day.